Go. All right. Yeah, so thank you. You've already given my title, so I don't need to read that slide. So I'll just jump to a list of our investigators with their pictures, thanks to this nice template. So here's our list of investigators coming from various parts of the University of Southern California. I'll add that there's a number of other people who aren't listed on this slide who also helped in the preparation of this study, including some of our medical students and other staff as well. In this talk, I'm probably going to give a little bit more of the descriptive results of some of our study, and perhaps this will raise more questions than it really answers, but I think that it's interesting to kind of look at some of these things. There's a lot of existing disparities in health as well as healthcare disparities. Some of that, although probably not most of it, is explained by barriers in access to primary care. And we know, especially in this group, that the COVID pandemic created additional barriers to a lot of things, including access to primary care, preventive care. I don't have to tell you guys, but there's lots of reasons for that, including reduced social contact, mitigation policy, and then importantly, as we talked about in the last presentation, the shift to telemedicine. So in terms of thinking about the impact of the pandemic on disparities in access to primary care and use of primary care, we want to think about, did this pandemic worsen existing barriers in access? How did it change how people accessing care through different types of health systems are affected? And one of the things that we are looking at in our study is how did this change between the safety net health care system and then also compared to a commercially insured population. So the results that I want to share today, fit into these goals and aims. So first, we want to measure the impact of the COVID pandemic on use of primary care among individuals with diabetes or hypertension. And then we want to compare patients from a large urban safety net health system to a privately insured set of patients and see how their use of care during the pandemic was different. And then this is a mixed method study. So we also had some interviews with patients as well as providers and clinic staff to sort of understand what were some of the things that people thought were explaining some of these differences in the observed outcomes. So the data we have comes from a number of different sources. So we have a commercially insured population from Optum Claims. So this is a nationwide commercial claims database. In this study, we're using data from 2018 through the end of 2021. We're working on getting access to the 2022 data. What we did is we took this sample and we limited it to primary care visits. We looked at only patients with hypertension and or diabetes. And then we also have data from the Los Angeles County Department of Health Services, which is a very large urban safety net system. So it has 4 hospitals, about 24 outpatient clinics. So it's a very large health system situated within LA County, which LA County has a population of 10 million. So it's bigger than something like 42 other states, right? So and we limited this data again to primary care encounters, patients with hypertension or diabetes. So the data we are getting from LA County is essentially taken from the EHR, and they've created an encounter database. And so for each data set, we compared monthly primary care visit counts among patients with hypertension or diabetes, both pre and post pandemic. And we looked at that. So I'll show you. Let me just talk about the methods for a little bit longer. For the qualitative interviews, we recruited people from the safety net system, from the LA County system. We talked to 4 health system leaders who are also providers. We recruited an additional 5 primary care providers, 5 clinic staff, including nurses, MAs, et cetera, and we talked to 14 patients. And so within those qualitative interviews, we explored barriers and facilitators to care, chronic disease management, and then we looked for themes and patterns. So here's some of our descriptive results. So this is just comparing people in commercial insurance to people within our safety net. And this is just in-person visits. So if we look at the number of in-person visits, and you can see, there's a clear drop that happens right at the pandemic. And this is, this is benchmarked to 100%. So you can see actually that in-person visits dropped in our safety net population to less than 20% of where they were pre-pandemic. And then it rebounds, but it rebounds only to about 80% by the end of 2021. Within the commercial claims, the drop is a lot lower. Obviously, there's still quite a bit of a drop, but it rebounds almost all the way to 100% by the end of 2020. So if then I put on top of that in-person plus video, so there actually is a red line there, but it's very small. So the number of video visits they had in the safety net system was just, it was like dozens. So they didn't really do a whole lot of video visits. And in the commercial data, we see that there's a substantial number of video visits. So then if we add in-person plus video plus audio, you can actually see this is now the dotted line shows you in-person plus video plus audio. And you can see now that the safety net system actually has rebounds actually really quickly, and actually at some point starts to exceed the previous pre-pandemic level. So one thing that is really apparent here is that there's really huge differences in terms of these health systems or populations in terms of use of video versus audio versus in person. And so the safety net system is really relying on, almost, it's at some points 60-50% of their visits are audio only, whereas if we look at the commercial population, we're seeing much more in terms of in person coming back much faster and use of video visits. So this is sort of like I said, this maybe creates more questions than it answers, but I want to share with you some of the qualitative analysis. So we interviewed system leaders and patients and clinic staff to sort of say, what was going on, and what was the one of the questions we had was, well, why did we see a lot of audio use only and not as much in person? So one of the things they pointed out was that there was inadequate telehealth and remote monitoring infrastructure. So clinic staff said things like, this is not only is, so let me just start with the second quote. There's some infrastructure with phone visits that they had already, but it was a lot harder to build the EMR tools to actually conduct telemedicine visits. And I think that that's consistent with other findings that some of these lower resource systems had more challenges in developing the tools to do telemedicine visits. There's also other things like, people would rather do it over the phone than in person, and they were maybe uncomfortable or intimidated. Some of them had data issues with phones, and there was a thought that, people using their data plans to do televisits, to do video visits were difficult. And then, there was patients saying that maybe there were some quality issues in terms of not being able to see the providers they wanted to see. There were also, and this goes into some of the other research we're working on, but there were backlogs in screening for diseases. So things like mammography really stopped for a while. They were ordering mammography, but it just wasn't getting done. And so there's another set of papers that we're working on cancer screening that goes into this a little bit more. There were also, I think this is another challenge that we're thinking about, is that there's a lot of the staffing shortages that happen sort of at the same time as the pandemic is coming as we're sort of moving away from the pandemic. So it's difficult to sort of measure, well, how much of this stuff is due to the pandemic and how much of it is due to workforce things. But there was a lot of concerns about staffing shortages leading to reduced access in this post-pandemic period. There were patient factors that came up a lot. There's patients that had fear about going to the hospital, doing in-person visits because they were concerned about COVID. Patients talking about having to go on public transportation to get to the hospital and having a fear of that. And then there was also this discussion of prioritizing higher risk patients. So they, for example, they had teleretinal screens for diabetic patients were stopped, but then they restarted really only for uncontrolled diabetics. So there was a thought of prioritizing these higher risk patients as well. As conclusions, there are multiple factors that may have left the safety net system unprepared, including lack of telehealth infrastructure. I will say, though, that there is some evidence that, these audio only visits are actually, quite, can provide high quality care among patients in the safety net. But I think it's interesting, and I think it's important to study, what is the effect of having these kind of audio only visits in this lower resource setting compared to other more high resource settings that have more video and more in person. So I think that in terms of thinking about the future, or if there's other pandemics or other emergencies, that we need to think about having these compensatory means to overcome backlogs and inadequate staffing and all this stuff. But that's what I have for today. So thank you. I'll let the next presenter come up.